Nonspecific neck pain is the clinical diagnosis assigned when a patient experiences chronic localized pain and restricted movement, but standard structural assessments reveal no apparent pathological etiology. For these patients, the vertebrae and discs appear healthy, despite the presence of persistent, severe symptoms. To find the physical driver, researchers examine muscle fat infiltration. Healthy cervical muscles are packed with dense fibers. This Prisma flow diagram details the study selection. From 1,261 initial records across medical databases, rigorous filtering left 4 qualified clinical studies. The methodology excluded whiplash or trauma, ensuring the final data represents a specific cross-section of chronic, nonspecific neck pain. The goal of this synthesis was to map the degree of fat infiltration against 3 distinct clinical outcomes: patient pain intensity, functional disability, and macroscopic cervical alignment. This data synthesis isolates whether chronic neck pain originates in the gross spinal structure or the microscopic tissue quality. Analyzing this condition relies on high-resolution MRI. Soft tissue contrast is required to differentiate lean muscle from fat, but diagnosing it presents a bottleneck. The first method used in the literature is semi-quantitative visual grading, relying on the Gauss-Tallier classification on T1 or T2 weighted scans. A clinician visually estimates the fat replacement on a 0 to 4 scale. Because this relies on subjective visual observation, it can fail to identify small, localized clusters of intramuscular fat. The second method uses quantitative threshold-based segmentation. Here, software isolates the specific pixels representing adipose tissue. By calculating the precise fat-to-muscle signal ratio, this technique outputs an objective percentage of cellular infiltration. Across the 4 selected studies, 2 used visual grading and 2 used quantitative segmentation. This methodological heterogeneity makes a direct one-to-one meta-analysis of the data highly complex. Recognizing how these studies measure infiltration is a critical prerequisite to interpreting the statistical relationship between the images and the patient's actual symptoms. Looking at the anatomical findings, the data reveals a clear pattern in the posterior cervical spine. The review isolated the deep cervical extensors, specifically the multifidus and the semispinalis cervicis. These muscles are responsible for segmental control and stabilizing the spinal column. Across the varying imaging methods, increased fat infiltration in these deep extensors consistently correlated with higher pain scores on the visual analog scale. Simultaneously, higher extensor infiltration correlated with higher scores on the Neck Disability Index, indicating severe functional impairment. Despite the different measurement protocols across the 4 studies, these 2 positive correlations remained consistent. The deep cervical extensors act as the primary anatomical zone where microscopic tissue degeneration dictates macroscopic patient suffering. Digging deeper into the data, the Huang et al. Study isolated a specific nuance regarding laterality. Fat infiltration does not always happen uniformly. Researchers found correlations between pain severity and fat accumulation heavily concentrated in the lower cervical segments on the right side, with no such correlation found on the left. This asymmetry indicates that fat infiltration is not a simple consequence of general systemic disuse or biological aging. If it were, the muscle decay would be symmetrical. Instead, this selective, one-sided pattern suggests the infiltration is driven by altered neuromuscular control, uneven dominant side loading, or habitual postural stress. An asymmetrical accumulation points to a localized mechanical failure or neurological adaptation. This makes the specific infiltrated muscle bed a highly targeted site for clinical intervention. The data looks different when we shift focus to the anterior cervical spine. Here, researchers examined the deep cervical flexors, the longus colli and longus capitis. The review found conflicting data. While one study showed flexor infiltration correlated with higher disability scores, another found 0 correlation between flexor fat percentages and the Neck Disability Index. Anatomically, researchers propose that deep flexor muscles may be less prone to lipid accumulation than the deep extensors on the back of the neck. To understand why fat accumulates in the extensors, we have to look at the physiological mechanism at play, the fear avoidance model of pain. Initial neck pain causes psychological movement avoidance, stripping muscles of mechanical loading. Without that stimulation, the fibers shrink and go dormant. As intermuscular fat fills the gaps, it introduces high levels of pro-inflammatory cytokines, causing further weakness and elevating pain signals in the surrounding tissue. Muscle fat infiltration is active, inflammatory tissue. It creates a self-perpetuating pathological loop that maintains chronic symptoms and progressive disuse. The review then evaluated the final clinical variable, gross cervical alignment, commonly measured as cervical lordosis. Clinically, a prevailing bias suggests a straightened cervical spine, losing the natural lordotic curve, is the primary mechanical driver of chronic neck pain. But when researchers map the data on muscle fat infiltration to evaluate this cellular decay against macroscopic cervical curvature, the results contradict that bias. The systematic review found zero correlation between fat infiltration and a loss of cervical lordosis. The data shows that severe pain, acute disability, and heavy fatty infiltration in the muscle all exist independently of sagittal plane structural alignment. The evidence indicates that microscopic tissue quality, not gross spinal curvature, is the primary anatomical correlate for chronic neck pain severity. For clinical rehabilitation professionals, these findings dictate a shift in treatment protocol. Fat infiltration in the deep extensors serves as a reliable, measurable biomarker. It provides a concrete way to assess the severity of nonspecific neck pain. Given the lack of correlation to lordosis, focusing exclusively on passive structural realignment therapies, like traction devices, addresses a variable disconnected from underlying tissue pathology. Rehabilitation must focus on active, targeted strength training that specifically isolates and mechanically loads the deep cervical extensors. Active loading is required to reverse the biological decay. Proper resistance training forces the muscle to adapt, reducing fatty infiltration, flushing out inflammatory cytokines, and restoring local neuromuscular control. True rehabilitation requires rebuilding muscle from the inside out. Restoring cellular tissue quality addresses the anatomical driver, whereas focusing on the spinal silhouette does not.